case of a white cataract with adherent leucoma that will be dealt with phacoemulsification. As can be seen, it's a big adherent leucoma covering the upper 1/3 of the cornea. Starting off with a side port incision, we inject intracameral mydriatic and anesthetic. Checking the extent of the adherent iris by injecting air. Another side port is made, trying to avoid the area of the adherent iris. And now once we have a good staining of the capsule, we proceed with the capsulorhexis. Trying to make the rhexis from the side port itself. In this case, we end up with a smaller than ideal size rhexis. And later on, once we have the main port made, we do extend it a bit so that we have a bit better visibility of the cataract. Now we begin phacoemulsification, and as with our limited access, we have a smaller axis and the opacity limiting our view. We went ahead with the divide and conquer technique. As the axis is not central, we do get 4 trenches that give us smaller but unequal sized pieces. That will be almost 5 pieces. The patient gave history of having this corneal opacity since childhood, and she had decent vision despite it. So that gives us a good hope of a good functional outcome. Continuing with our trenching motion, we do try to see the smaller pieces, and once the final crack is achieved, we can then start eating up the pieces. That we make good progress of the remaining pieces, and in these cases it is important to maintain the good viscodispersive fill throughout the surgery, and to minimize manipulation, I'm dialing some of the pieces that are remaining for better access and minimal damage to the cornea and the rest of the interior chamber. Just ending with the last few pieces, and we've successfully removed the pool of cataract. There's next to no cortical matter remaining, as we see in white cataracts. So injecting hydrophilic acrylic IOL in this case, we see the leading haptic go easily into the bag, but the optic does get stuck. And trying to dial it in, we see that the anterior capsule is ripped apart, and that is simply because the rhexis was too small for this lens to fit in. It is quite a bulky lens, and ideally we should have extended the capsule, the opening, much bigger. So as an aftermath, we do ensure that the capsule and the lens are in proper place. Thankfully, the whole of the lens is in the bag, and just trimming the part of the anterior capsule to keep the visual axis clear. And after that, we aspirate the remaining viscoelastic and close up the wounds. Now talking about the outcome of this case. So I'm happy to report that 1 week later, we had a clear cornea, and the patient did very well, was able to read 6/12 unaided, and was quite happy. So my learnings from this case are that always decide the capsular axis as per the visibility, and it's important from the start to finish. Methodical approach with divide and conquer is always dependable, and play it safe and maintain a good viscodispersive fill in such compromised corneas. The take-home message would be, in these old and thick adherent leucomas, avoid the area of opacity, do not make any incisions, and do not do any manipulation there. Maximize the size of capsular axis as much as you can, follow your trusted techniques, and always maintain safety in these corneas. Thank you. We have a case of a white cataract with... Thank you, sir.
So, Dr. Agam, nicely presented.
Thank you, sir.
There are a few questions from my side. First of all, when I think because of the trauma itself and the damaged iris,
Yes,
the pupil was very small.
Yes, sir.
So, was there any use of any pupil expanding devices or any hooks or any ring or anything that you would be needing to in these cases, especially in cases of trauma?
Yes, sir. Sir, in this particular case, we could get away without it. But if we do have a smaller than, say, this iris, we would need either best would be to use 1 or 2 hooks.
Yes.
To separate.
Never use rings in such cases,
yes,
because there are adhesions behind, and you might be
Be an issue.
causing more damage rather than giving an advantage to
Yes,
the patient.
Yes, sir.
Yeah, that is very important. And many times the adhesions go up to full to the anterior capsule itself.
Yes, sir.
And there is a clump of cataract, traumatic cataract, which does not get removed. So if you
Yes,
see
sir.
there, you will find that in many cases, it was not there in this case,
Yes.
but usually you will find a plaque of cortex adhering to the anterior capsule.
Yes, sir. Yes.
So that would be causing a problem, and we might get very overzealous sometimes in getting it removed.
Yes, sir.
For getting it removed. So we should avoid that because the pupillary axis is clear.
Yeah.
And anyhow, if any cortex or anything is left, we can go for the posterior capsulotomy later on. So very nicely managed. And the advantage of the hooks I was telling was that you can actually manage the pupillary. You saw that there was a tear in the rhexis margin while
Yes, sir.
implantation.
Yes, sir. Yes.
So, and also during the process of phacoemulsification, when we were managing the nucleus, so if it is very small, the pupillary, you know that if the rhexis is small,
Can get
it would,
damaged,
yeah,
yes,
because in cases of trauma, you don't know the status of the zonules also, even if it is old. Was there any phacodonosis or iridodonosis pre or present there?
No, sir. We
No,
did check dilated and dilated.
Yeah,
That
it was not
thankfully
there.
It was not there.
But anyhow, it can lead to a more stress on the zonules also.
yes.
And you saw that while implanting the IOL also, it was a little bit difficult because you are going through that. And if it would have been a, like say, PMMA or a 3-piece lens, so in that case, it would have been little difficult for you to go inside the capsular bag.
Definitely, sir.
So that is one of the takeaway message that we can add on to this video. Otherwise, very nicely managed, and usually these cases are little difficult ones.
Yes, sir.
Very nicely. I congratulate you on managing it nicely. Thank you.
Sir.